Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. This is part 2 of Basics of Electrocardiography. Topics covered in this part 2 are conduction system of heart, concept of vector of electrical impulses, principles of recording by electrode and details about ECG paper. The first important structure in conduction system of heart is sinoatrial or SA node. This is where the electrical impulse of the heart is generated. Hence, it is also called as natural pacemaker of the heart. Three internodal bundles arise from SA node, which are anterior, middle and posterior internodal bundles. They conduct impulse from SA node to AV node and along their way activates right atrium. Another bundles arise from SA node, which conduct impulse to left atrium. This is also called as Bachmann's bundle. As you can see, Bachmann's bundle is little longer, causing slight delay in conduction of impulse to left atrium. This results in left atrial activation lagging slightly behind right atrial activation. This concept is very important in understanding formation of normal as well as abnormal P wave. Next important structure is atrioventricular or AV node. This acts as a checkpoint for electrical impulse of heart. Conduction through AV node is so slow that it takes almost 90 milliseconds for electrical impulse to pass through AV node. This is called as AV nodal delay. AV node continues as bundle of His, which penetrates fibrous tissue plate between atria and ventricles. Fibrous tissue plate acts as an insulation and allows the impulse to pass only through bundle of His. Along the left subendocardial area of interventricular septum, bundle of His divides into left and right bundle branches. As important structure of conduction system of heart are present in left subendocardial area of interventricular septum, septal activation occurs from left to right. This concept is important in understanding formation of physiological Q waves. Left bundle branch divides in tree and branches pattern to form two divisions or fascicles. Anterior division conduct impulse to anterior and superior wall of left ventricle, and its direction of conduction is like this. While posterior division conduct impulse to posterior and inferior wall of left ventricle, and direction of its conduction is like this. Concept of direction of conduction of anterior and posterior fascicle is important in understanding ECG changes of fascicular blocks. In ventricular wall, just beneath the endocardial surface, division and bundle branches further divides into Purkinje fibers, which travels transmurally from endocardial to epicardial surface. With this, we conclude the discussion of conduction system of heart. Let's start with the concept of vector of electrical forces. There are thousands of myocardial cells in heart. Each myocardial cell have its own electrical activity. If ECG records electrical activity of each myocardium separately, ECG would have been a non-comprehensible pattern of zigzag lines. Instead, ECG machine records vector of electrical forces of all myocardial cells. That's why we get only one ECG complex for each heartbeat. But question is, what is vector? If you remember from your 12th standard physics, vector has two components, magnitude and direction. As principles of vector for electrical and any other forces are same, we can understand how forces add up to form vector using real-life examples. You must have seen a car dashing a running bike. In this scenario, bike speed will increase suddenly and then it will fall because of imbalance. Why does this happen? Because after dash, force of car plus force of bike add up to form resultant vector, and its direction remains the same, that is in forward direction. So, if forces are in same direction, the direction of resultant vector remains the same, and magnitude of the resultant vector will be summation of original forces. Now imagine a game of tug of war between team blue and team yellow. Both have 3 players and they are of equal strength. there will be no movement of rope even if lot of force is applied on it. This is because force applied by blue team and yellow team are of equal magnitude and opposite in direction. That's why the resultant vector will be 0. If a player is added to blue team, force applied by yellow team will be same, but force applied by blue team will increase by a fraction. Now there will be little movement of rope toward blue team. This is because a resultant vector will be directed toward blue team with magnitude equal to blue force minus yellow force. So if forces are in opposite direction of resultant vector will be the direction of larger component, and magnitude of resultant vector will be subtraction of the original forces. You must have seen a handboat. If a stroke is made with left pedal, boat will move forward but sway slightly toward right. So the direction of force will be like this. If stroke is made with right pedal, boat will move forward but sway slightly toward left. So the direction of force will be like this. Now, if stroke is made with both the pedals, boat will move forward but without swaying in any direction, and its movement is slightly greater than both previous example. This is because the resultant vector is directed in forward direction and has a magnitude greater than individual forces. From this example, we can conclude that if forces are in different direction, then direction of resultant vector will be different than the original forces. However, it may be more inclined toward direction of greater one. And magnitude of resultant vector will be greater than the magnitude of original forces. But it will not be a simple summation. So how these concepts are applied in ECG? Magnitude of vector of electrical forces of heart will not be simple summation of all the forces. Forces in opposite direction will cancel each other. As musculature of left side of heart is greater, vector direction is inclined toward left in normal heart. In pathological condition, direction of vector can change if direction of electrical forces changes, as in conduction block or in hypertrophy or atrophy of heart chambers. Magnitude of vector can give idea about cardiac muscle hypertrophy or atrophy. Let's start principles of recording by an ECG lead. There are 3 basic principles. If vector is directed toward positive pole of a lead parallel to lead axis, it will show a positive deflection. If direction of vector is away from the positive pole of the lead, exactly opposite to lead axis, lead will show a negative deflection. If vector is directed perpendicular to lead axis, resultant deflection will be equiphasic in nature. That is, its positive and negative deflection will be equal in amplitude. More often than not, vector direction is not in any of these 3 directions. In such cases, what will be the pattern of ECG wave? To understand this, let's take a perpendicular vector. It will form an equiphasic deflection. If direction of vector is moved gradually toward positive pole, negative deflection will goes on decreasing and ultimately a complete positive deflection is formed. Similarly, if perpendicular vector is moved gradually toward negative pole, a positive deflection will goes on decreasing and ultimately a complete negative deflection will be formed. I hope with this you have understood how direction of vector in relation to lead axis will decide pattern of ECG wave in the given lead. In normal ECG, QRS complex vector is directed toward lead 2 in frontal plane and lead V5 in horizontal plane. Hence, these 2 leads show highest R wave amplitude amongst respective plane leads. But the question remains that why does lead axis of lead V5 starts from center of heart? Where is the negative pole? So here is the answer. Negative pole for all precordial lead is called as neutral or indifferent electrode. This electrode is formed by a combination of right arm, left arm and left leg electrode. Peculiarity of this electrode is that potential of this electrode at any given instance is 0. And that's why it is assumed to be placed at center of heart where potential is 0. Let's start details of ECG paper. It is nothing but a graph paper we all used in our school days. It has two axes. X-axis is horizontal and represent duration of ECG waves, and Y-axis is vertical and represent amplitude of ECG waves. It has small boxes which are 1 mm square and large boxes which are 5 mm square. Each small box on x-axis represent 40 milliseconds and on y-axis represent 0.1 millivolt. Each large box on x-axis represent 200 milliseconds and on y-axis represent 0.5 millivolt. These values we just discussed holds true only when calibration on x-axis is 25 mm per second and on y-axis 10 mm per millivolt. Let's understand what is actual meaning of this calibration. When calibration on x-axis is 25 mm per second, it means that 25 mm on x-axis represent 1 second, which are nothing but 1000 milliseconds. So, one small box of 1 mm on x-axis represent 1000 divided by 25, that is 40 milliseconds. And 5 mm large box represent 40 multiplied by 5, that is 200 milliseconds. When calibration on x-axis is changed to 12.5 mm per second, then one small box represent 80 milliseconds and one large box represent 400 milliseconds. Similarly, when calibration on x-axis is changed to 50 mm per second, one small box represent 20 milliseconds and one large box represent 100 milliseconds. On y-axis, normally used calibration is 10 mm per millivolt. This means 10 mm on y-axis represent 1 millivolt. So on y-axis, one small box of 1 mm represent 1 divided by 10, that is 0.1 millivolt. And one large box represents 0.1 multiplied by 5, that is 0.5 millivolt. When calibration on y-axis is changed to 5 mm per millivolt, one small box represents 0.2 millivolt and one large box represents 1 millivolt. When calibration on y-axis is changed to 20 mm per millivolt, then one small box represents 0.05 millivolt and one large box represents 0.25 millivolt. Let's determine duration of P wave and amplitude of R wave in lead 1. Here P wave is 2 boxes wide. Therefore, duration of P wave is 2 small boxes, that is 80 milliseconds. R wave is 8 boxes tall. That means amplitude of R wave is 8 small boxes, that is 0.8 millivolt. Now let me ask you some questions. Can you tell me amplitude of R wave in lead 2? Please write down your answer in comment section. My second question is, what is this thing in the circle? If you know the answer, please write it down in comment section. If you don't know the answer, please watch the next video. Topic for next video will be normal ECG, where details about waves, segments and intervals in ECG complex will be discussed. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.